Good evening, tribe. Chelsea here. We are talking with Jenny tonight about being a trauma nurse. Welcome, Jenny.
Hey, guys.
So introduce yourself. Tell us a little bit about you.
Hey, guys, I'm Jenny. I'm 35 years old. I'm a mother of 2 kids. I have a 4-month-old and I have a 5-year-old daughter. I have been a nurse since March 1st, 2010. I started my nursing career in Cleveland, Ohio. Go Browns. And I started on a very busy post-op surgical oncology ENT floor. And then we moved to Virginia. We are 30 miles south of Washington, D.C. And I work at a 18-bed level 1 trauma ICU in Falls Church, Virginia, Inova Fairfax Medical Center.
Awesome.
I've been there 7 years.
Okay, great. Awesome. And have you been in trauma the whole time?
Yes, I have.
Okay. Awesome. That's great. So guys, those of you that are tuning in, welcome. We're glad that you're here. Go ahead and just enter your questions in the comments. And as the questions kind of fit with the flow of the dialogue, then I will ask Jenny those questions. She wanted to start out with a video that is from her home unit, or not her home unit, excuse me, her home hospital. And so I'm going to show that. I'm going to take the video out of YouTube and let you guys see it. You can enter in questions as we go, and then we'll get started with discussing our question and answer session with Jenny. So let's see, put that in here, and here we go. Oh, okay.
Loudoun County Sheriff's Office. Someone accidentally stabbed themselves?
Yeah, he jumped on the couch and there was a knife.
This is, 11-year-old? Is this your brother?
Yes, this is my brother.
Is the knife still in him, or?
Yes, the knife's still in him. I left it in. I covered it up with like a paper towel. My mom and my 16-year-old brother are at a driver's ed thing, and I'm 15.
Like I said, we got a bunch of units heading out there right now.
You need to stay away.
It wasn't something that you can prepare for. You don't even think to tell your children, now don't put your steak knife in the couch cushions. Yeah, you just don't think you can't prepare for that.
When Tate came in, I looked at his initial x-ray as we were rushing to the operating room, and I thought, oh my God, I don't know that I can save this boy. Because where that knife was in the center of his ability to live. I'm looking at that x-ray saying, don't cry, because it's going to demoralize the whole team. But I could feel the tears welling up in my eyes, just looking at it.
One of the doctors came by, and I remember asking her, I said, what do I need to plan for? And she said, you need to be prepared to not take him home. I always prayed that I would be able to accept God's will, but for God's will, please, to not be to take Tate.
Trauma surgery is the ultimate puzzle, and you need all of the pieces to work correctly and to end up with a picture that you can hang on your wall. Tate received CPR 3 times. The aorta was sliced completely in half, right through the kidney. So we immediately removed the kidney so we could get to the aorta, and we put in an interposition graft. We kind of MacGyvered that. I remember Dr. Hashimi coming in and him saying, looking at what we were doing, and him saying, I've never seen this before. And I said, that's great, just come in and help us. It was just about at shift change. We had the crew that was basically getting ready to go home. They stayed. The new crew came in, and they assisted as well. So we actually had 2 crews of people working for hours to keep this boy alive. When the bleeding stopped, I looked up at Dr. Grant, and her and I just looked at each other and thought, maybe he's gonna live.
Tate was a great example of the teamwork of Fairfax. The first few nights, we had people offering to come and help from all over. And then we also had to have so many specialists consulting for his care because of his injuries.
He lost one of his kidneys, cut his aorta in half, damaged his liver. There was an infection in part of his colon, so they had to remove it. We had to do a surgery on his leg because it swelled so much that they thought they were going to lose it.
He was truly Humpty Dumpty, and he had truly fallen off the wall, and we were trying to put him back together.
I'm a control freak, and I connected with Nicole on noticing that she wanted to be in control, she lost control, and she was terrified.
I don't like relying on other people, especially with the boys, because they are mine to protect and to take care of and make sure that they're okay. The nurses up there that I dealt with were amazing. They allowed me to be very involved in taking care of Tate. 12 hours later, he's still there. 24 hours later, he's still there. And so you've made it over that hump, and now you move on to the next. Okay, well, now what?
Then once you get through all those critical aspects of things, then you got to convince him that he can get out of bed again.
Both have you. Are you ready to take some steps, bud?
Once we started working through rebuilding his confidence, you got to see him smile. You got to see him joke with his siblings and laugh with his mom and smile with his dad. And then all of a sudden you're like, wait, this is not the child we admitted. This is the child who he was before he came through those hospital doors. You realize this is the miracle that we all work for. This is why we come to work every day.
The accident was January 24th. We were discharged March 3rd. And he walks fine, runs, jumps, everything that they said they didn't know if he was going to be able to do.
Thank you to all the doctors and nurses that helped me out when I was in the hospital.
Tate is here because he ended up at a children's hospital, and because the team that was there, because the EMT was the group that came to the house. I think that everything had to happen exactly the way that it happened. I believe that that's because that's where God wanted them to be.
This is where your money is going. Your money is going to save the children, but we need help with education, with outreach, and with patient care.
I've been a pediatric nurse for 20 years, and there's no better return on your investment than supporting children's health. How can you not want to save the kids?
All right. That was awesome. Okay. So, those of you that are tuning in, I'll say it again. You guys go ahead and get your questions in, and as they fit in the dialogue of the conversation, I will ask them. So, welcome, Jenny. I'm so glad. I know that was a tearjerker. That kid is amazing. That team is amazing. I'm glad you shared that with us. We've never done that before, so I'm sure the tribe will give feedback as to that they liked that and enjoyed that piece. Where do we start? So, what all have you done in nursing? Did you start in trauma?
No, I started, I worked so in the Midwest, there's a lot higher rates of cancer. So I actually started on a very busy post-op surgical oncology ENT floor. So we were taking fresh trachs, we were taking fresh flaps, we were taking head and neck cancer revisions, dissections. And through that process, I was like, I like surgery. I like tearing stuff up, removing stuff, drains. I like surgery.
Mm-hmm. That's awesome. Do you feel like trauma in and of itself is a good place for a new grad to start?
In a trauma ICU, it's very cutthroat. We're very honest people. Specifically in thinking of my ICU, either you survive or you don't. Unfortunately, the culture still is there that the older nurses will eat the young, and I don't support that at any means. But you have to have, first of all, you have to have the guts to see the blood, look down and see brain on your shoe. You have to have the stomach to be able to see blood and deal with people at their worst times, and as well as their good times.
So this might be a good, appropriate time to ask, how do you deal with those nurses that are eating their young? How do you handle that situation as a leader?
As soon as I hear, and we have high turnover due to a lot of people going to school. We try to filter, we try to hire yes, we'll hire some people from the ED that want to transition up, but we try to hire from the outside. We do a lot of team building activities. We'll go to so-and-so's for dinner. We'll do baby showers. We'll do Santa gift exchange just to try to bring people together and like to stop the petty betties from just destroying our unit.
Good for you. So what's the process of training a new trauma ICU nurse, whether that's a new grad or an experienced nurse that's coming to you?
So for new grads, they get a total of 16 weeks working one-on-one with a preceptor on our unit. They get a ton of education, which it's really overwhelming. And then for a person that's coming in, say that maybe have 1 or 2 years of experience, may it be ICU or med surg, like floor transition. I had 12 weeks coming in from a technical floor. A nurse being hired in with ICU experience gets 6 weeks. And then again, they also have to have all the classes as well. Some of them have to do echo, which is like extra learning. And then they all have to do a core of trauma classes that we offer.
Okay, great. So what's your favorite type of trauma patient?
Honestly, my favorite type of patient but it's a motorcyclist who is a blue-collar worker who has gross fingernails. He's rough, he's tough, he's gruff, sometimes ladies. He swears at you. He may or may not be a drinker, but like, I love bikers. Like that's who I love. But then I also like a patient who, I'm trying to think, circling the drain, like a bad TBI, bad head injury, big bleed. We've taken you to the OR. We've taken, the bleed out. We've tried to stop it. And then we're playing with the drugs to keep you sedated enough, to keep your blood pressure up, just the mechanics of trying to save someone. And then it's incredible, like what we do. And then there's times where last week we had a woman that was hanging her shower curtain, slipped and fell, and on the bar degloved her middle finger. And so we had to use leeches. Yes.
That's awesome.
Yes.
Okay, so let me see. I have pictures of leeches. Do you want me to show those now?
Yes, please.
Okay. Let's see. I'll put those on the screen for.
Yep, there they are. So guys, these are medical grade leeches. We don't just go out into the lake and scoop them up. They are medically grown in a fancy sterile farm. They are used for if you're worried about a patient that has a lot of venous congestion and clotting off that section that you're trying to reattach. They're kept in a cold environment. They're really expensive. As you can see, they're in an ice bath there. And then Chelsea, if you want to show one of the other 2 head pictures. There you go. Nice. So this was a patient who worked at a bakery in Northern Virginia and had gorgeous flowing hair. I mean, like I wanted her hair. Okay, it was really nice. The wind caught just right, and it got caught in a huge KitchenAid mixer and ripped her scalp off. The EMTs literally brought her scalp back in a bag of ice. The plastic surgeon, of course, rushed her back to the operating room in hopes of reattaching her, the scalped part, in a way that we would be able to, down the road, fit her better. It would be a better fit for a wig, for a hairpiece for her. So guys, as you can see, she had just received 2 units of blood, and those are leeches literally on her forehead. The picture on the left, there are probably, I think I remember putting 10 to 12 leeches on her head to try to open up those areas that we're trying not to let die of her scalp. And in the leech's mouth, they have like heparinized saliva. So they're able to heparinize that area and keep it open. And once the leeches will eat, get fat, and fall off, and then we wrangle them and then put them in alcohol to kill them. And this poor woman, the surgery didn't go, and it was no fault of anybody's. It just was a very bad area, and unfortunately, she ended up we were not able to save that chunk of scalp right in the front there where the majority of the leeches are. But she came in 2 weeks ago, and she had her hair was kind of starting to grow back, and then she had a hair piece in the front.
I'd take that. That'd be all right. All right. So let me go back to that. Okay. So leeches. What else do you guys do with leeches? What else do you treat? Or some other wounds that you've seen used?
Okay. So let's talk wounds. We are a trauma surgical ICU, big open bellies, broken legs, broken arms, broken heads, broken faces. We've seen fire pokers through someone's belly. I've seen someone impaled by a wooden fence. You name it, broken lips, broken jaws, broken penises, like you name it, anything. People can break anything.
Sure. So what all have you guys used leeches specifically for?
Leeches are just basically our big plastic cases. Like again, her finger, the lady's head. I've used them on like ENT neck flaps.
Okay.
Yeah.
That's interesting. Anyone in the audience seen leeches used? That's pretty cool. So you want to talk about massive transfusions?
Sure. Do we have any questions before I dig into that?
Yeah, if anybody has any leeches questions, now's the good time to ask. Okay, I think everyone's just all ears for you. We've got lots of viewers, so.
Okay, so recently we had, and the video that I showed earlier, Tate received, I think a total of, throughout his like 3-month hospital stay, he received 87 units of packed RBC red blood cells. So he received quite a few. Of course, when you sever your aorta. But as far as MTP, mass transfusion protocol. So let's talk about that for a second. I'm giving you a ton of blood product in a very short amount of time because I need you to have that volume. I need you to have that blood pressure. I need you to have that pulse. MTP can only be initiated by our trauma surgeons. The ER docs can suggest it. Other docs, such as cardiac, can suggest it. Med-surg docs can suggest it, but only our trauma surgeons can order it. So what's going on? First of all, it's an all hands on deck. I'm bringing in my big machines. I'm bringing in 2 or 3 coolers of blood products. I'm bringing in special labs. I'm bringing in a ton of team players. Chelsea, do you want to show the 2 different machines?
Yep. Please.
The 2 different machines that we currently use, and my favorite, this one is called a level 1. It is the easiest machine to use. You can see right there is a big number 1, and then if we had a closer picture of it, you can see step number 1, step number 2. Very, very simple to follow. Your blood can either be on your right side or your left side, and then you'll always have a bag, of normal saline to flush the blood through. Preferably, you want more than an 18 gauge IV, 16s, and we're going with 14s. I need something big, or a central line if we have time to jam one in. Chances are we're going to jam one in your IJ, or we're going to jam one in your femoral. Don't have time. Next, we're going to do usually 2 to 1. We'll do 2 PRBCs, give you a liter, and then we'll do either an FFP. You cannot run platelets through it because we will smash those platelets, and our blood bank is very stingy with our platelets. The other machine that it's on the floor, it's available. I don't like it. It's called a Thermocore. It's kind of, I'm not gonna lie, it's kind of archaic, and like you have to find the cassette and press all these buttons. It's not numbered and easy to follow like the level 1 is. Still kind of the same concept. You hooked up your blood product with the normal liter of normal saline, and you kind of alternate blood versus other products. You put blood bank on notice. As soon as you activate that MTP, you're putting OR on notice. You're putting CVOR on notice. You're letting people know, hey, this patient is getting pretty sick. We don't like to MTP for a long extended time period on the floor. We like to stabilize them and then get them off of our unit into the OR. We have, chances are, if OR is MTPing someone, they'll find the source of the bleed, stitch it up, duct tape it up, and send them back to us to try to stabilize them even more.
Gotcha. So a couple of questions about the mass transfusion were asked. What type of access did the patient have, which you already answered, but I think most of us would think, oh, well, they probably had a central line, and generally speaking, they don't.
Nope. We don't have time.
Okay. Right.
I mean, from the field, if we're MTPing someone from the field, chances are they're flown in. I'm not transfusing through a 22 gauge. I need something big. I need a 14. I need a 16. If I have an 18, we'll try to use an 18, but it's not preferred for obvious reasons. We're jamming in a ton of volume of fluid. We need access.
Yeah. Another question about massive transfusion was, what machine did you use? And you answered both of those. And then did they make it to the OR? And I think what she was asking, maybe that you were talking about a specific case, but generally speaking, I'm not quite sure which.
Sadly enough, and this is the last night shift that I worked. Sadly enough, the patient was just too unstable to get to the OR. He came directly. It was actually happened right down the road from here. Flown in from the scene of the accident to the trauma bay, and normally they'll do like a series of CT scans to see what exactly is broke. Unfortunately, he was too unstable to do any sort of pan scanning, and then got him directly to our unit, and we MTP'd that poor man for 8 hours, to the point where blood bank called us and said, we have nothing more to give you. Nothing more to give. We're going to have to fly it in from Hopkins, and it would be an hour.
How do you weigh that out? I mean, I know we're talking about someone's life, but I mean, how do your providers weigh that out?
It was tough because you could visibly see an open femur or bilateral open femurs, bilateral open humeruses, but we didn't know his extent of his head injury. And I've had a patient go to OR, with a bad, I've had a patient go to OR and have a subdural bleed, and he's lost 3 liters out of his head. Like, wait, what? 3 liters out of your head? Yes, you can. We just kept trying. He was a young kid, a dad, like 28 years old, a dad, and a dude high on heroin with a Narcan pump hit him head on. And it was just a matter of, we don't want to give up. We don't want to give up. Keep going. And then finally we're just like, we've got nothing more to give.
Yeah. Do you want to talk about the potential bone loss for injured bones? Put that slide up.
Sure. Okay. I was like, bone loss. Yes. Believe it or not, guys, you can lose a crap ton of blood from just simple breaks in your body. As we can see, a rib, you can lose 125 mLs. That's a lot of food. That's a lot of blood. A femur, because if you think of someone's thigh, and my thighs are bigger because I'm a big girl, but you think of someone's thigh, that's a lot of blood you can be packing in there. Like, just a lot. And then a pelvis, if you don't find the source of that pelvic bleed, or you don't like think to put on that pelvic girdle or that pelvic binder, you're going to lose a lot of blood, and it's going to go quick. Those are big, nasty, big bleeds.
Let's see. All right. So someone asked if you use maggots at your hospital.
No, I love playing with bugs, not snakes, but not yet. In my 9 years of being a nurse, I've never been exposed to maggots. I mean, would I like to? Oh, sure, but not yet. Maybe somewhere down the road, but not yet.
I've only seen them used one time. It was very interesting. Yeah, and it was also a scalp wound, actually. All right, so guys, we're not getting many questions, which is unusual. I think they're all just enamored by what you have to say. So do you want to talk about the abdominal wound vac that you
Let's talk about big bellies. Let's talk about a belly.
Big bellies. Yeah, let's talk about belly. Okay, let me get that slide up.
Big belly. All right, guys. Big abdominal surgery. I'm trying to think. Grandma comes in. Grandma's had a small bowel obstruction for a few days. We take her to OR. And you just get in there and it's a disaster. The belly is a nasty, nasty place full of very vital functions. So this is literally what we call an open, obviously, belly. It has we call it a ghetto wound vac on there. It looks like a real lily pad and whatnot, but it's probably hooked up to a suction canister. Like, you're losing so much fluid from that belly and just leaking everywhere. So you're in depth. What is underneath that blue foam is, you can bet that someone's intestines that are angry, mad, and swollen they're mad. You can bet there might be some liver under there. Who knows? But there are numerous cases that we get patients back and they literally have a huge basketball sitting in their abdomen. There's so much swelling and those bowels are so angry that, I mean, you can clearly see there's no way the trauma surgeons can close that belly. So they come up to us. They can be intubated. Chances are this guy's, I don't know what you can see is ET tubing, but he's intubated. He's going to stay intubated. That requires a bedside washout every 2 days. Monday, Wednesdays, and Fridays, we are going to turn that patient's room into an operating room. They don't take time to go to the operating room. They do it right on our unit. We do close the unit to visitors until that procedure is over. So we're going to peel away that saran wrap. We're going to take that blue foam off. And what are you going to see? You're going to see like noodles in there. You're going to see his bowels just hanging out. Go in there. We'll take some warm saline, wash it out, suck it out, wash it out, keep track of what's going in, what's going out. A ton of insensible loss in there, you guys. He's just like gooing, like God only knows what out of his belly. I've seen people stay open for 2 years. I've seen people stay open for 3 days. I mean, it all depends on on the amount of swelling. Due to that high insensible loss, chances are you're going to have problems with your blood pressure. You're going to have problems keeping that blood pressure. You're definitely going to have a central line. You're definitely going to have an arterial line. You're definitely going to have a machine that we hook up. It's called a Vigileo that keeps track of your cardiac numbers. You're going to remain intubated. And that sort of belly is going to take a long time to close. And bellies, they're full of infection. They're full of nastiness, but they're fun to play with. And like you can even see in that picture, there's some bowel hanging out at us, just waving at us. Hey, how you doing? So they're big, nasty. They can be young people. They can be old people. They can be male, female, race. It doesn't matter. But if your bowels are so angry and everything's so angry and inflamed, and you've got the Cersei response going on where everything's inflamed, you're not closing that belly, and it's going to be a while. But the problem with an open belly is so you've got everything splayed open, and what's here laying? You've got your fascia, you've got your skin, and it has no blood supply when it's open. So when they eventually get around to closing that belly, they're going to have to put a bunch of mesh and a bunch of grafts in there to be able to close that, because all that surrounding tissue and skin and fascia going around that hole is all dead because there's no minimal blood supply to it. So closing that is a huge day in itself, but it also comes with a lot of problems as well.
For sure. So we've got a couple questions come in, or in mostly actually statements. Someone says, "You're awesome." Who said that? Susan says, "You're awesome."
Little crazy. Thank you.
Melissa says, she's good and knowledgeable. And then Susan said, "Use antibiotics with that rinse."
Not like inside the rinse, but no, just like person's on, chances are they're on like a fluconazole, which is diplocan. You just want to have broad spectrum antibiotics, and sometimes they are and sometimes they're not, but bellies are nasty and they have a,
so they don't typically use an antibiotic infused solution when they're doing the rinse.
Yeah.
I think is what she was asking. Okay, that's interesting. Good thought, Susan. So what are some things or some reasons why you would leave a belly open? Trauma to the abdomen. What other things? Just to give us an idea.
It's like we see a lot of, like, when we'll take out a spleen, you have swelling in your liver, you have a ton of, you're losing, like if your liver's pissed off, it's going to bleed a lot. We'll leave it open. Also, you guys have to think about, say I have a patient up there who's, laying there and all of a sudden they stop peeing, but I know that they have had some sort of abdominal trauma. Why have they stopped peeing? Let's do a bladder pressure to see what the pressure amount is inside that belly. Bladder pressure measures the amount of pressure inside a person's abdomen, right? So I do, I set up my, like, it's like an art line setup. So I set that up, and then all of a sudden I get the bladder pressure and it's 30 plus. Oh crap, something's bleeding. And you got to think about it anatomically. Something's bleeding and it's creating pressure in that abdomen, and now it's kinked off or compressed my bladder. So something is bleeding in that abdomen, or swollen or angry or has died, to make those bowels, make that liver, make that pancreas, make whatever you need to get angry and swell. And you have to think of swelling like, is it bleeding? Is it dead? Is it on the way to being dead? Is it, there's a few different reasons as to why someone's belly would look like that.
Awesome. Good info. So what kind of characteristics do you feel like makes a nurse successful in your environment?
To be quite honest with you, you have to be tough. You have to know when it's okay to cry with people. You have to have a heart. You have to have, you have to be able, like I said, you have to be able to stomach when you turn someone who shot themselves in the brain and you turn them and they literally spill brain on your shoe. You have to be able to be like, and move on. You can't sit there and make a big deal out of it, because chances are the parents are sitting behind you and they saw that brain fall on your shoe. You can't, you have to have the mental mentality to be like, ugh. But you can't, you have to be mentally strong in order to deal with that. You have to have character. You have to be a tough person, but not so much that you lose a patient and you don't go in the back and cry for a little bit, or you take that person down to the operating room to harvest 10 or 12 organs. You have to still be human and be tough at the same time. And like, there's numerous days where I come home and I cry because I've lost a 27-year-old. I've lost, an 18-year-old. But then there's days where, like with the video that I showed, Tate literally walked out of the hospital. And you have to be able to balance your highs versus your lows. You're going to have highs and you're going to have real low lows.
Sure. And those of you that aren't sure what she's talking about at the video, if you've just tuned in, I will post the link to the video in the initial post whenever we're done and concluded here. Okay, so speaking of loss and all those highs and lows, how do you decompress after a stressful shift? Does your unit offer like debriefings and things like that?
So in thinking of one of the lowest lows, and if you, Chelsea, do you mind showing the 3 pictures? It's the police and then the like them lined up?
Yes. There's
So
that one.
in trying to balance the highs with the lows, it was a Saturday night. It was 3 years ago, and I was up getting ready, getting ready for bed, and I received a text from our babysitter, or from our sitter, and she's like, "Are you listening to the scanner?" And I'm like, "What? No." She's like, I was listening to the scanner, Miss Heather said, and it said, cop shot, cop down, 187, all hands on all hands. And what it was a domestic violence situation here 10 minutes away from my house. And an individual shot and killed his wife, and had numerous domestic problems. Shot and killed his wife. 911 is called. The neighbors are like, "What's going on?" Officer Gwendon showed up. Officer McEwen and Officer Hampton show up. And Ronnie answers the door, actually with his 11-year-old son in front of him, and proceeded to open fire pushed his son out of the way, proceeded to open fire on a massive amount of cops. Unfortunately, Officer Gwendon lost her life, and Dr. McEwen is now, like, he was shot up head to toe, and Officer Jesse took a few bullets to his leg. It was by far the worst day we've ever had on our unit. Officer Gwendon came in talking to the trauma bay, and then just all of a sudden decompensated so quickly. At that time, we also had an 18-year-old code blue come in who needed an operating room now. We have 7 trauma surgeons. The trauma surgeon from day shift ended up staying, and the other 6 ended up coming in just to help out because we were so busy that night. We deal a lot with law enforcement. We love our law enforcement, and unfortunately, to have to deal with this sort of situation still rocks our unit to this day. And we just had the third, I don't even want to say anniversary, third memorial of when Officer Gwendon had passed away. That was one of the lowest points in our trauma unit, and still is something, it's a very sore subject. The other picture that Chelsea showed was on the right side is our hospital ED there. That is when they took Officer Gwendon's body to the medical examiner's office, is the military and firefighting personnel lining the streets, taking her body out of our hospital. It was really hard. So you just have to be a tough person, but then just know that times are going to get tough, but you just have to rely on your coworkers to comfort you and to talk things out. Unfortunately, I don't know if it's just specifically our hospital, but we do a terrible job of, after we lose a patient, okay, pick up this next person. Like, there is no debriefing. You can, take a minute to yourself, but it's an expectation that you get back in there and you pick up a new assignment and you pick up a new patient. Like, I had a case 2 weeks ago where I took a 19-year-old motorcycle kid to the OR for organ harvest, and I stayed down there 2 hours, and then they called and said, okay, we're getting a new admission. You need to come back up here. You've done your duty, come back up here and get right back in it. And that was really hard.
Yeah.
So we do a terrible job of debriefing.
Maybe that's something you guys, or that you can, you're in a master's program, you probably can't head it up, but maybe someone that also has passion for retaining staff could head up like a debriefing council, and you guys can get that started. Because how often do you guys lose nurses because they feel like they can't cope?
Crazy enough, we lose nurses because a lot of us are done doing bedside. And a lot of us are going back to CRNA or FNP school. Occasionally we'll lose someone like military, husbands PCSing out, but every once in a while.
So your staff retention is pretty good.
I'm sorry?
So your staff retention is pretty good.
It's more for school. It's not just like someone can't cut it, because we're, like I said, we're really deep throat. Like either you're going to make it and like we know pretty much in a week or two whether or not you're going to fit in with our personalities, our way of doing things. It's very cutthroat, unfortunately.
Yeah, I hear you. So I'm sorry you guys dealt with that. That's really heavy. And I'm really thankful for the work that you do in the trauma bay. Is there anything else you want to cover? We've exceeded our 30 minutes. And if anybody else has questions, get them in so that Jenny can answer them. Do you have anything else you want to cover, Jenny, before we go?
Like I said, guys, it's fun. It's great. We have good days. We have bad days, but that's any job you have, we work so great as a team, like taking care of our patients, and we see them at the worst, at the absolute worst. And then to see someone literally walk out of there after they've been there for months and months. Well, they may not walk out, but it just makes everything that you do all worth it. And we have such a strong team. Is there problems in the team? Yeah, there's always problems in the team, but like, we work together so well. We work one-on-one with our doctors. Like there's some in surgery, there's big personalities, which you're going to have with surgeons. We all know that, but it's so worth it. Like, I love it. Every day there's something different, whether I'm not an LPN, but like there's days where I'm like head LPN, both grandmas have fallen and they both have head bleeds, and they but then there's days where like, you're taking care of someone who's literally circling the drain, and you see it on the news, the background, and we're under lock and key. We're a secure unit. We have security at the doors. We're seeing gang violence on the rise again. And it's like, really? Domestic violence, we take care of prisoners, which is kind of cool. They're chained to the bed. Drunk drivers, people, high DC officials who are drunk driving, like, come on, the homeless guy on the street, we take care of anybody and everybody.
Mm-hmm. That's awesome. So Susan just said thank you, and you're getting lots of thumbs up and hearts going through the live. So we appreciate your time. We really do. I know you're working hard trying to finish up your classes, and so we truly appreciate you giving us your time.
Thank you. Anybody else have any questions, comments, statements?
And if you guys have them as you're watching in the replay, just get them in. And if Jenny doesn't see them, I'll alert her to them so that she can answer those for you as you guys watch on replay as well. All right, guys. Well, have a great night, Jenny. And you guys have a good one. Be safe out there, guys.
Trauma's fun. Come play.